Morning. Morning, folks. If I can have your attention, we get started. Thank you all for being here on this rainy morning, and welcome to our April breakfast with the expert. This morning, I am delighted to welcome back to campus Mr. Wilkes, Associate Administrator for Johnson City Medical Center, the flagship hospital of Ballad Health. It's always a wonderful morning when I have the opportunity to introduce our breakfast with the expert speakers, but it carries a very special meaning when our expert guest is one of our alumni. So Bo is a graduate of our MPH program in Health Services Administration. And since his graduation, he has been highly engaged with our programs and our students. He has served on advisory committees. He has guest lectured, precepted students, and supported, again, our programs and students in many different ways. So thank you so much for that. He is also had an exceptional career in healthcare administration. He has progressed through leadership roles in healthcare administration at a remarkable pace, assuming increasing responsibilities, always exceeding expectations, promoted to more senior roles, and just being a good steward and a good citizen and a friend for our region here. So his story is certainly an inspiring story, but this morning he is here to share with us his perspectives and thoughts on the story of Ballad Health. So thank you so much for taking the time to be with us, and I will turn this over to you, and we're excited to hear and learn from you both.
Good morning, everybody. Excited to be here. So I graduated from the MPH program in 2007, and really just been blessed to be at Legacy Mountain States and now Ballad Health. One thing I will note to caveat, especially since this is being recorded, Johnson City Medical Center is the flagship of Legacy Mountain States, and we are going through the process currently, and I'll speak to that in a little bit more as far as what it looks like for Ballad Health moving forward. So kind of as was noted, I'll tell a quick story before we get into this. Kind of as was noted, graduated in 2007. Upon graduation, because I came straight out of undergrad into grad school, upon graduation I wanted a little bit of a break, and so I had the opportunity to go work for ESPN for about 18 months. So I spent 18 months at the age of 24 and 25 traveling North America and working sports. And for me, that was an absolute dream come true. Had a great time going to Super Bowls and World Series and various other things. But at the end of the day, healthcare and public health was kind of where my passion was. So I wanted to get back into it. And I tell you that because I started off in Mountain States in our grants department. And I started off as an analyst, and I worked my way up. And I had spent about 5 years in the organization, 6 years in the organization, when our current executive chairman of Ballad Health at the time, CEO, Mr. Alan Levine, arrived. And he arrived in January, and this journey, January of 2014, this journey kind of began in March of 2014. And it's a fun story because at the time, the easiest way to put it is I was serving as chief of staff for our CEO at the time. So I kind of filled the white space around our senior team. So if there was a joint venture going on, I would kind of go out and get that up off the ground, collect the initial data, and then turn it over to one of our executive teams. So it was still a great opportunity and had a lot of exposure, but I was still trying to figure out exactly where my professional career was going. So I was sitting at home on a Sunday night in late March. It was about 10:30, and I got a text from Mr. Levine that said, "Bo, are you awake?" And surprisingly enough, Sunday, I typically try to get in bed early just because it was a new week, and My roommate and I were awake, and so I responded. I said, yes. I said, what's going on? And he said, I need you in Atlanta tomorrow morning at 8 a.m. That was very different for me. And I said, okay, I'll look at flights. So I pull up flights, and at the time, and still is the case, our travel policy was for us to book the flights, and then the company would reimburse. Over this 60 days, Mr. Levine and I had built a good relationship, and we were known to play some practical jokes on one another. And so when I pull up that the flight from Tri-Cities to Atlanta was going to be between $1,200 and $1,400, I sent a text back saying, are you sure? And his simple response was yes. Probably should have been enough information. However, I reached out to our COO, who I knew was with him at the time, and said, hey, Marvin, Alan's asked me to be in Atlanta tomorrow at 8 a.m. Flights are really expensive. Are you sure I need to be there? I get a text back, yes. Should have been enough, right? Well, it wasn't. I texted Mr. Levine back and I said, okay, I'm getting ready to book my flight. Is this for real? And he said, Bo, I don't care if you rent a car and drive here overnight. I want you here at 8 a.m. So I ended up booking my flight. I flew down. I was out on the 6 a.m. flight, so I was in Atlanta at 7 a.m., having no idea what I'm walking into. I knew that a couple of members of our senior team were in Atlanta, but I wasn't 100% sure what was going on. And so I go to the hotel where I'm supposed to go, and I walk into a room. There is 8 attorneys, all from, we're not talking like local attorneys, we're talking like from major firms out of New York City. There are 4 bankers, and then there's our CEO, COO, and CFO, and then there's me. Now, who in the room didn't belong? That was me. So we kind of usher in, we do small talk, we sit down, and we begin to have the conversation of what it is we're there for. And at the time, I learned that Wellmont was exploring opportunities to partner within the region, and we were going to submit a proposal. And so I'm sitting here going, wow, this is going to be a great learning experience. I'm probably just going to be collecting data, maybe getting coffee, who knows. But still, this is going to be a great learning experience. So the org chart pops up. And under that, the lead drafter is me, and my hand immediately goes up without thinking. I'm like, what? Huh? You want me to do what? And that began what we thought was going to be a 6 to 12 month journey that turned into 3 years, and I'll explain a little bit why. That began the story of what is Ballad Health. So I'll talk about this a little bit later, but our tagline is true to that. It's the story of our region. We're rooted in that from an Appalachian perspective, and we want to listen. We want to understand, and we want to grow. We're creating a new culture. Ballad, by definition, is typically a story from an unknown author, and I think that is very important and very powerful. We're no longer Legacy Mountain States. We're no longer Legacy Wellmont. We are Ballad Health, and we're creating a new story together. So with that in mind, I kind of framed up my story. I'll kind of set the origins of the story. I'll talk a lot about the transaction. Within the origins, I'll go ahead and tell you that there is a lot of doom and gloom. However, when we get to the back end, I'll try to pick everybody's spirits up. So everyone absolutely does have a history. And what we found out as we began to discuss our name or to brand our name, history was very important. So we didn't want to lose sight of that. So who are the characters? Mountain States obviously was a 14 hospital system based out of Northeast Tennessee and Southwest Virginia. The unique thing about this merger is we were merging with our direct competitor, and that was Wellmont Health System. And so at the time of the merger, they were 7 hospitals, really and truly a lot of overlap within the same service area that we were serving. But competition is not always effective within healthcare. And I think that's very important to remember, and I'll speak to that. But as we began to look through, we wanted an innovative way to try to transform healthcare, to turn it upside down. And I think we created that model. So as you begin to look at a lot of different things, geography becomes very important. And I realize, and I'll explain this, I'll try to draw a picture since it might be difficult to see. here we have a mountain range sitting in the valley, and you could guess this is kind of our region. It's very important to understand that referral patterns are dictated a lot by access. I know you've learned that, you've discussed that numerous times. So you have this mountain range, you basically have North Carolina here. You've got a lot of funneling going this way. You have Kentucky up in here, so again, geography and access is funneling it down into this way. And then you have 81 and 26 kind of cutting through. 26, there's just not a lot of population here, so it's difficult to disrupt that. So again, as you kind of throw the map up, you can see Johnson City here, Kingsport here, Bristol here. Geography in this region really begin to get at a lot of what you guys are learning in public health. And that's very important because at the end of the day, access is going to dictate a lot. And so how do we improve that access? You know, obviously in Johnson City, in Kingsport, and Bristol, we have access points. But how do you improve access points in Mountain City while at the same time being profitable? And I know sometimes that's a dirty word when we think about that from a healthcare standpoint, because you want to be able to provide healthcare in any way, shape, or form that you can. However, it's a business. You have payroll to hit, you have physicians to employ, you have physicians to recruit. All of while trying to meet this hospital demand and operation that's going on. So the current model wasn't working. We had access points here, but as you got into the rural area, it was being difficult, and we have poor health as is no surprise within this region. So how can we begin to improve that? On top of that, discharges were declining. And so as you look across the region, historically, we have been a healthcare system that's fee-for-service. You go to the doctor, you get paid. The doctor gets paid. You go to the hospital gets paid. You go to a clinic, the clinic gets paid. And so the old model, the incentive was, just come see me. You know, you come in, oh, doc, I've got a chest cold. Okay, great. We're going to do x-rays. I'm going to get paid for that. We're going to do blood work. I'm going to get paid for that. We're going to maybe do another x-ray. I'm going to get paid for that. Okay, I'm not 100% sure what's wrong. I'm going to send you to a specialist. You walk in with your films. You hand the films to your specialist. The specialist goes, okay, great. These are wonderful. Set these aside. We're going to do x-rays. We're going to do blood work. And we're going to do one more x-ray. And they're getting paid every single time. So you're beginning to see how healthcare got out of control. So as you look at that, this region in particular was very abusive, I guess is maybe not the right word, but overutilized healthcare. And so as you begin to see, there's two things going on. So you have the national norm that's normalizing, you're becoming better managed care, but also you're having the region that has typically been overutilizing healthcare that's also right-sizing, and so you just see this rapid decline of discharges and admissions coming into a hospital. As no surprise, inpatient hospital care is the predominant funder for health systems. Does anybody have any idea typically how many outpatient visits equate to one inpatient visit? This is interactive. I'll try to wake you guys up. It takes about 4 to 4.5 outpatient visits to equate to one inpatient visit. So as you begin to see the shift, it really begins to impact change. Okay, so we've built these massive hospitals, and now the number of patients that are coming into these hospitals are changing. So you look at a lot of different things where we've built these grand things during the bust or during the boom of the industry and the economy, and now everything's starting to change. So we're starting to have to think differently how we're doing a lot of this stuff. On top of that, you know, we're looking at the region. This is just going on regionally. Well, then, as no surprise, there's things going on in the industry. So we're getting hit twice as hard here because our region's changing, but so is our industry. So as you begin to look at that, I started talking about kind of the fee-for-service model. As the government is beginning to look at a lot of different things, they're trying to start cut, and this is just Medicare payments, which is the largest government, or the government is the largest payer within health systems. But this is the reduction in what Medicare is beginning to pay out, modeled through 2025. This is billions, 32 billion, 48 billion, 82 billion, 103 billion to 143 billion. Huge numbers.
And that's nationwide?
nationwide. This is just as a whole, so it's not necessarily going in. And it's coming in a lot of different areas. So these are big numbers. So on top of the utilization within the region, on top of within the region is a population decline, or at least a flat population. You also have these payment cuts. So what else does that mean? It's also hitting our teaching hospitals. So GME payments, graduate medical education, are also being impacted. So healthcare right now is being hit from a lot of different directions. So again, as we sit around and begin to think about these things, the current model is not sustainable. As no surprise. But what's the answer? I think everyone's scrambling to try to figure that out. So as I mentioned, this blue line depicts, from a Medicare perspective, this is outpatient volumes, which is a cheaper cost of care, and this is the inpatient volume. So again, remember, from an inpatient perspective, that's where margins are a little bit higher, and that helps healthcare systems and hospitals. So as a hospital has a margin, we can then redirect it into our physician staff, we can redirect it into clinics and outreach and population health and all these different things. And then on top of that, as you begin to look at some of these things, cardiac services, as is no surprise, historically has been, from an inpatient perspective, very good margins for a hospital. So is vascular. So as you look around this region, the largest thing that you guys are probably aware of, if you're mindful of kind of what's going on, cardiology in this area is booming. But when I say this area, it's really Johnson City, Kingsport, and Bristol. So if you live in Mountain City, great, we've got a cardiologist for you. Drive an hour down to Johnson City. What if you can't afford to drive down to Johnson City? What if you don't have that access? What if you're too sick to do that? What if you don't have someone to drive you? So these are all the things. And then you look, as the baby boomers are aging, the outpatient orthopedics is growing. So again, all the things that you're learning, this is reinforcing kind of what's going on in the industry, and it's only going to continue. It's not going to stop. On top of that, technology is rapidly changing. You know, you hear of Apple, Google, various industry, outside industry getting into healthcare to disrupt healthcare. They feel like that there's an opportunity there to grow. And so, whereas historically, kind of the emergency department, the higher acuity things, this is kind of where we all went historically in healthcare. Now everything's beginning to shift. You know, if I've got a cold, I can simply pull up my phone, click an app, and I can be FaceTiming with a physician somewhere in the United States or somewhere in the world and say, hey, doc, I'm sick, I'm not feeling well. And they can potentially even assess you just through FaceTime. So everything's beginning to change. And then on top of that, outside industry is really starting to get interested in healthcare. They feel like there's a significant opportunity. No better example than retail clinics. So just look, this is in 2000, and by 2008 there was about 1,100 clinics, and now by 2017 they estimated that it's about 2,800 clinics. So it's booming. The latest is Walmart wants to acquire an insurance company. Why does Walmart want an insurance company?
So wanting to get into the healthcare system as well.
They want to get in, but it also, Humana already has the analytics engine on how to manage their folks. They can go ahead and dump all their folks. They can get some synergies and leverage that as well. But then they also increase the patient population that's now being overseen within that. It's not just their employees.
Another thing too is a lot of people who shop at Walmart, they're usually lower socioeconomic, so they have a lot of health issues as well.
Right. And so people like Walmart and Home Depot are getting radical in what they're doing. I can't remember what it is. I'll say it's Walmart for just it's slipping in my mind. But open heart surgery. If you're a Walmart associate, there are 6 places in the United States. Virginia Mason out in Washington, I think Hopkins, Mayo, and a few others, that they will pay you and your spouse 100% to go and have surgery. If you want to go to Johnson City Medical Center and have your surgery, I believe it's like 10%. Why are they sending it to those 6? They have proven lower cost and better outcomes and a shorter length of stay, so that reduces the amount that the organization has to pay for healthcare. Competition in healthcare is no longer what we have historically defined it. People are willing to go to great lengths to move it throughout the industry. I believe UPS does something very similar. So elective surgeries, they block routinely 2 weeks. They rent basically an OR within a hospital. They bring in their physicians that they've identified, and they basically just churn through providing those elective surgeries because, again, better quality, lower cost, shorter length of stay is cheaper to them. Healthcare is changing, and this is a perfect example of how it's doing. Virtual visits are a reality now, and virtual visits are changing the way that we do medicine. So as we begin, again, coming back to Ballad, as we begin to think about Legacy Wellmont and Legacy Mountain States, and we're beating each other up over what we can do and how we can get that done and how we can get more market share, the rest of the industry is well beyond that. And so we knew as we were beginning to sit down and think about things, we had to go there. We had to start thinking that way. It's funny, shortly after we closed the merger, we were sitting in Mr. Levine's office and kind of all just reminiscing on the journey that had been. And he made the comment, he joked to one of the Wellmont senior vice presidents, and he said, you know, as you look from my office, there are 9 Wellmont signs, 9 within view of his office. And he just said, you know, that is crazy that we're spending, you know, that much money on marketing, that we're duplicating services, because within that probably same view was a Legacy Mountain States Hospital and a few other clinics, and so it was duplication of services completely. But the executive from Wellmont laughed and he said, yeah, there would have been more, but city code wouldn't allow it. As you begin to think about these things, sometimes we have to come together and think about things in a little bit different way. So on top of that, and a lot of this you guys have probably seen and discussed, risk really comes into play. And so as I mentioned kind of what Humana is doing, they're trying to pull their risk together to kind of reduce that percentage that's truly at risk so that they have a larger population that's helping subsidize the 80-20 rule, if you will, that's helping do that. And so you kind of have increasing financial risk across. You have kind of the pay for performance. So as you're looking at the kind of the quality metrics, you know, if you have improved quality and kind of lower that cost, we share in that. The bundled payments, the shared savings, the shared risk, all the way to full risk. So there are times that you could go to an insurance company, and you know, I know that it's been discussed numerous times with like a Blue Cross, but if you go to Blue Cross and say, on average, what is your patient spend for your population coming to Ballad Health facilities? And if it's $1 million, we can say, great, pay us $900,000 and we'll manage your patient population. And whatever that cost savings is, then we can go ahead and try to share that savings amongst us, but going completely at risk. And so what do? We have to begin to manage that patient population. We have to do a better job of that. And that's really where healthcare is going, is how do you shift from treatment to kind of that preventative care aspect. When I first, actually when I was in college, when I was in grad school, I was working at Johnson City Medical Center in patient transport. And I'll never forget, I walked into a patient's room and he was going down for a few tests, but the next day he was going to have a cath. And he was eating McDonald's cheeseburger. And I guess the look on my face at the time, probably being 19, was probably not appropriate, but I looked just in bewilderment at this gentleman who was obviously having heart issues. He was going for a cath and he's eating a cheeseburger and fries from McDonald's. And he just looked and he went, what? They're going to suck it out of me anyway. What's it matter? But that's not changing that behavior, obviously. And then on top of that, there's a lot of conversation going around about insured and now this new underinsured aspect of things. And so, and this actually happened to us, there's now these high deductible plans with HSAs and all these great things that are going on. Some people that we've realized have actually health savings accounts. They don't know that they have them because of the high deductible plans. And so they're coming into these with $10,000 deductible that they're not being able to hit. And then they're getting hit with a $9,000 bill and they're not being able to pay it. And so it's going to bad debt and it's going to charity care. And so we have a lot of people across the country that fall under this uninsured. And as we were going through conversations with the state and looking at some of this stuff, that was a really big conversation because the definition of exactly what underinsured is still kind of gray. And so how do you begin to look at that? Just because I have insurance doesn't necessarily mean that I can actually afford to use my insurance. So there's been this requirement from the Affordable Care Act, which in thought is a great idea. Let's just mandate that everyone get insurance. Great, seems like a great idea. But to reduce the cost, we create these high deductibles, and then that doesn't necessarily actually produce a product that's relevant. And so when the ACA first came out and they were talking about this boom and this increase in number of people that are actually covered and insured, our bad debt was rising at the same time. So we had folks coming in and saying, hey, great, I have insurance, but I have $10,000, and if this is going to cost me $9,000, I'm not going to be able to afford it. And then on top of that, we found out that some of our own folks who the organization was contributing into their health savings account didn't realize what that was, and so they were coming and saying, I can't pay for this, not knowing that even we had a health savings account over here. And so again, consumerism, we're starting to flip it back onto that. But it's a radical way of managing our health. And people are beginning to shift in that direction, but for the most part aren't used to it. So what's the resolution? What's the idea? We began to pursue, as this opportunity was available, a cooperative agreement with the state of Tennessee that ultimately became a cooperative agreement with the Commonwealth of Virginia. Within the state of Tennessee, there was what was called a certificate of public advantage. And I'll kind of expand on that in a minute. But as we began to look across the country, this was beginning to somewhat take hold on a small scale. So you have smaller systems kind of combining within the Northeast. You had a couple, Palmetto Health was a 2-hospital system in South Carolina, North Carolina right across the way, Mission Hospital, which was created from 2 hospitals literally on opposite blocks of each other. They combined resources, but nobody had begun to look at it at the scale that we were talking. We're talking 14 hospitals combining with 7 hospitals across 21 counties. Big. And so as these conversations started, it was change, it was different, and it was risky. And sometimes that's hard for people to wrap their head around. Now, our leadership is their personalities lend themselves to that. They love excitement, they love energy, they love new things. How can we create something different? What can we do? Let's come together, let's try to build a radical model. And so as we started looking at these things, we started to really understand that the biggest thing that we needed to do is the benefits had to outweigh the disadvantages. As simple as that. And so what does that mean? Obviously, we need to be able to improve quality. Cost is a big thing. And so based on state law, we had to meet one of these 5. Avoidance and duplication, got that, boom, we can knock it out. Improve hospital resources and equipment. Absolutely, we can do that. We can right-size things and make that happen. Cost efficiencies, obviously coming together. We can do efficiencies. Preserving hospital facilities. At the current time, Wellmont had closed, Legacy Wellmont had closed 1 hospital, and who knows what would have been on the horizon for Legacy Mountain States as far as hospital preservation. And that really becomes important. and then obviously enhance quality. So we have to meet one of these. We're going to meet all 5. And then all of a sudden, people start going, okay, it's a risk, it's radical, it's different. Now it just sounds too good to be true. Flags are going up, antennas are going up, and there's starting to be a lot of resistance around us. So we really began to dig deeper into this, and this presentation will be available, so I won't begin to read a lot of this, but we really started to dig deeper into this and feel like this was truly an opportunity to partner, to come together as 2 organizations, but also partner with the state of Tennessee, with the Commonwealth of Virginia, with our major industry within this region to truly improve things. As you begin to look around this region, the 2 major industries now are probably education and healthcare. Southwest Virginia, it used to be coal. That's no longer the case. So if we want to continue to grow this region, we need to leverage those 2 industries to grow and to attract people to this region. It's a beautiful region. I'm from here. I'm a little biased. If you're not, let me tell you all about it. It's great. But there's definite opportunity. And so with all of that, we really started to think, we can do this. We evaluated the acquisition of Wellmont, obviously where we were financially, that was risky, but we felt like there was a way that we could come together as equals and create something radical. And so we started the story. So as with anything, especially that lasts about 3.5 years, there's transformation. And so we began to look that one of the major things that we wanted to do is we wanted to keep our decisions local. And I know it's been talked about, but I don't think it can be sold enough. As you begin to look around, you have, and I'll use a perfect example, you have HCA trying to acquire Mission Health in Asheville. HCA is a for-profit, which Legacy Mountain States and Legacy Wellmont are not for profit. So it's a completely different model on top of that. But what does HCA have to prove to their shareholders about the acquisition of Mission Health? It's got to be profitable. And so how do you get that profit? How do you get synergies out of Mission Health? Well, for one, they own their own corporate billing office. They have an entire company devoted for that. That's gone. 500 jobs. We no longer need a robust as C-suite as you have. That's gone. Those are some high-paying jobs. What does the governance look like? Well, obviously HCA it's an acquisition, so I don't know if it's going to be an 80-20 joint venture, but more than likely it's going to be a full-on acquisition. So all of a sudden local control. So if that were to happen locally, let's say that Legacy Wellmont were sold to a competitor, and I'll be unrealistic to try not to go too far, but let's say it's sold to a company in New York City. All of a sudden New York City's making the decisions on what we need. And then let's say on top of that, Legacy Mountain States has to go and sell to a company in Los Angeles. Now New York City and Los Angeles are making decisions for what happens in Northeast Tennessee and Southwest Virginia. That begins to create issues. Sure, they have local leadership that's funneling back and telling them what's going on, but it's not necessarily making the right decisions that we need to make. Access is truly not important. Quality is important from a reimbursable standpoint, but is it the best decision? And it also depends on what partner you're picking. So that's important. So we wanted to ensure that the folks that our physicians are going to the grocery store with, this is kind of the story that we told, are interacting with our board members, that our board members kind of understand what's going on here. Now, Ballad Health, the ultimate board that was created, we have some lay people that own small businesses in the region, but we also have Dr. Nolan. We have the general counsel of Eastman Chemical. We have Scott Niswonger. We have the lay person, but then we also have significant titans within their industry that are helping make these decisions, but they all reside here. They all access care here. They all raise their children here. Their families are here. Their neighbors are here. And that cannot be undersold. So obviously, local governance is not the only decision that's going to drive a merger, right? So let's begin to lead by example. Mr. Levine came from he's part of the Florida Board of Governors, which is the Board of Governors that oversees the Florida education system. So University of Florida, Florida State, Central Florida, South Florida. In addition, he's a graduate of Florida, so I don't know if you've ever seen, but he's obviously very passionate about the University of Florida, and so he would always come and have conversation about the research that's going on at Shands and UF. And as you look, ETSU gets about, I think a little over $2 million at the time this was beginning, I don't know what it is now, from NIH funding. And then if you factor what that economic impact is locally, let's say it's a multiplier of 2, you have that much money going into the local economy, which is great. That's outside money coming in to stimulate our economy. Well, then you look at some of the titans within NIH funding who are receiving $100 million. All of a sudden, $100 million multiplied by 2 going into the local economy is huge. So how can we come together and then partner with our academic partners like the College of Public Health, College of Medicine, College of Pharmacy to begin to truly do research on what's going on locally. But then also, again, coming together to improve quality, to enhance services. And then ultimately, obviously, the big part is to ensure that we're financially viable for the future. So we're doing that, and some of the ideas we originally came up with and some of the ideas that exist now is the Children's Hospital exists. At the time, we were competitors, and so obviously Legacy Wellmont's pathway was normally to East Tennessee Children's in Knoxville. So if they had a pediatric specialty that they couldn't meet, they were sending it to Knoxville. And so it's really hard for the Children's Hospital to get critical mass to be able to make certain programs financially viable. Then you have 3 hubs. Trauma is a huge one. There are 6 level 1 trauma centers within the state of Tennessee. There are 2 within 25 minutes of each other. There are 2 in the entire state of South Carolina. Why is that important? Trauma is not profitable. It loses millions of dollars. Think about it. Somebody comes in, and typically we get paid on a DRG basis. It's only one DRG, but they come in with multiple issues. And it is, if it's a true trauma, all different kinds of things going on. And so it's stabilization, it's long lengths of stay, it's follow-up surgeries, it's a lot of different things that we're trying to stabilize. And so now all of a sudden you have 2, which in theory seems like a really great idea, but also it's impacting potentially quality because there are metrics out there to say that if you get X amount of volume, that's going to improve your quality results. If you're only doing traumas once a week, it's really hard to stay current. If you're doing it every single day, obviously you become more comfortable within that environment. And then the academics piece is very important. As I mentioned, beginning to partner, and a lot of great things are starting to beginning to partner with our academic institutions around the country. So Dr. Wyckoff, thank you. Paula Masters is coming to be our Vice President of Health Programs for Ballad Health. Is going to be a phenomenal asset to the organization because it's truly changing. It's a space that we've never really operated in, that she has tremendous expertise in, while I think it also continues to reinforce our bridge into the College of Public Health, into ETSU, whether it be medicine, pharmacy, whatever it may be. So again, really beginning to think about, hey, this might actually be a great idea because we're being able to take some of these synergies and position them elsewhere. I mentioned about cardiology. So again, typically Legacy Wellmont recruits in or Legacy Mountain States recruits in a cardiologist, they're probably going to go do the same thing. That's not productive. What about pediatric subspecialties? What about endocrinology? What about, you could go down the list. It's beginning to reposition where our financial assets are going. And then ultimately, which is really big, this is where our industry got excited, is we feel like that we can improve quality and we can lower costs for our employers. So Eastman Chemical Company is self-insured, and so obviously they have a huge stake in what healthcare cost is. They want to support this region, they want to support the local systems. However, if they adopt a model like whoever one of the major industries do, major organizations do, like Walmart, and beginning shipping their patients elsewhere to improve that quality aspect, it hurts care locally. And so lowering that cost structure helps our local organizations to be able, as opposed to paying for what they currently have, if they're saving enough, they can reinvest into what they currently have. So that begins to grow our region. And I think that's important. And then ultimately trying to retain jobs. Can we begin to create enough stuff that actually excites people to stay here? And then once we keep people staying here, can we begin to recruit people in and truly create something dynamic? So that was the initial proposal in late 2014. It's now, April 4th of 2018. Obviously, it evolved. And as we began to do that and get successful and have conversations, we also wanted to begin to think about who we were as an organization. And no better way to state that than developing your brand. And so we started to do a lot of research. And as no surprise, with the International Storytelling Center here, storytelling is a significant part of who we are. And as they began to have conversations, not just within the legacy organizations, but had conversations with the community at large, what kept resonating to them was the difference in that storytelling aspect. And it became about country music. And it became about conversation. So as we began to explore this, everything kept popping up in the same light. They surveyed 2,000 random blind sampling. The company that we used called 2,000, I believe, residents, so a small sample size, residents within the community. And typically when they do this, they ask them questions, or what's important to you, and typically it's, well, quality, or I want to be better, or I want to, I'm sick, I want to be healthy, in essence. That was number, I think, 4 or 5. The top 3 were, I want to know my doctor, I want to be able to have a conversation with my doctor, because we are different. We're Appalachia. We have the rural aspects of things. We're very much rooted in our history here. And there's a lot of great people here. And they just wanted somebody to stop and to have a conversation with them. What does this mean that I have cancer? What does this mean that I have diabetes? Talk to me. Change that conversation. And so as we began to come through this, as we started to think about who we are and what our brand is, we began to understand that we, as we're transforming how we do healthcare, that we have a part in this, and that our team has a part in this. Whether it be the housekeeper that's walking down the hall and conversing with the patient, a transporter that's taking someone to their next test, a health program that's doing outreach within rural Appalachia. We needed to stop, we needed to have a conversation, and we needed to listen. And so with that, we created Ballad. And so as I mentioned, one of the things that we really, really, really wanted to ensure that we did was move away from our legacy systems. We often categorized our initial conversations as Friday night football. They love nothing more, and we love nothing more than beating them, whatever it was. A bigger sign, recruitment of a doctor, the first to open an urgent care clinic. Didn't matter what it was. It was competition, which in a free market is great. Fantastic. In healthcare, it's a little bit different because everyone is coming to see us in all different shapes and forms. Some people taking care of themselves, some people not. Some people don't, afford care, some people not. And so we understood that, but most importantly, we wanted to move away from where we were and move to where we're going. So, as I mentioned, it evolved over time. Shortly after getting started, it actually wasn't made public until sometime after the Federal Trade Commission popped in, paid us a visit, and said, "We don't like what you're doing." We said, "Well, the great thing about the United States government is state action immunity, keeps us away from the Federal Trade Commission, and so we're going to continue dialogue with the states, and if they see value in this, then we'll be okay." And they said, "Okay, great, but we're going to continue to have conversations with you." At the time, and I think this is made public, so if it hasn't and it's being recorded, oops. We got a significant request from the Federal Trade Commission that took me about a month to pull down. I think there was roughly 20,000 documents. So let's say that they were 10 pages each, which they were much more than that. It's 200,000 pages. It was probably more like 2 million to 20 million pages. And so we're sending all that to the state. And then the Commonwealth of Virginia gets involved, which we're very excited about. They set up a model that allows us to engage the Southwest Virginia Health Authority. So we began having conversations with them. How can we improve things? How can we partner? How can we get better? And so we started having great things and great conversation with them, and our proposal began to change. And at this point in time, we were together, unified, we being Legacy Wellmont and Legacy Mountain States, we were together, unified, working with the Southwest Virginia Health Authority to understand what their concerns were, to understand what their views were, and began to shape what we were trying to create. So once we got that done, then we began having conversations with the Department of Health and the Commissioner of Health within the state of Tennessee. And when we thought we were done, we started to have different conversations, and it began to shape and change what we were trying to build. So then once we got that done, we had to go back to the health authority, make sure that they were comfortable with it, a few minor tweaks, and then back to the DOH, and then the Attorney General had a part to play. All the while, the FTC is looming large. So as we're having these open meetings, it never failed to have a conversation and go, who's on the line? And it was such and such from Commonwealth of Virginia, such and such, state of Tennessee, Southwest Virginia Health Authority, da 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 da. Anybody else on the line? Yes, this is John Smith from the Federal Trade Commission. And at that point, because of who the FTC is, everybody was, it's the FTC. And so again, going back to, it's radically different, and now the FTC is involved. And so there was a lot of navigating that occurred, a lot of conversations that occurred to try to understand what the concerns and the hesitations were, to make sure we were doing the right thing, but ultimately be going to set ourselves up for success. And so as all of this, and I'll explain this, sorry, it didn't turn out as well as I wanted it to. As we were going through all of this, we needed a structure to be successful. It was numerous work streams, various work groups, within two different systems that needed to operate. And so we began creating a box for hospital operations. Very important, merging two systems. Now the problem is the FTC says under no circumstance can there be any collusion. And so strategy, salaries, what you reimburse, any of that stuff, we could not have any discussions prior to being merged. So then you had information systems, you had brand development, research, system innovation, population health. You had the supply chain and the finance aspect of things. You had simple things like foundation, strategy, quality, nursing leadership, and then the clinical council, which was an ultimate council created with our physicians from each one of our hospitals to ensure that our physicians had a voice and were readily engaged in this conversation. So we started to have all these work streams. And throughout this, I was positioned to ultimately, I guess my title was executive director, but I served directly for the Ballad Health Chief Operating Officer, who was named initially Marvin Eichhorn, and I was basically air traffic control for all of this. So I mentioned going back in January of 2014, here I am, Chief of Staff, kind of filling in this, trying to figure out where I'm going with understanding that I keep my head down and I keep moving forward. My favorite quote is kind of bloom where you're planted. So no matter where you're trying to come up through a crack in a sidewalk or you're in a beautiful garden, try to be the best flower that you can be. And so as I began to look at that, I began to transition into this role. And so I was afforded the great opportunity over 3.5 years to work with all of these as we began to set our plans to do this. All the while, the FTC was involved, and Virginia was involved, and Tennessee was involved, and local folks were involved. There's a lot of different things going on. But as we began to set all this stuff up, we began to sit down, and this was one of our initial slides that we set up, which ballooned well after that. But as I began to think a lot around this, we wanted to hit the major things which we knew we had to do day one. We needed a new brand day one. We needed a nursing leadership structure day one. We wanted the clinical council to be developed day one. We had plans that were required, so we needed to be sure that we had those structures up and ready so that day one we could start, because we had 90 to 120 days to get the initial draft submitted to the state to begin their review, which is coming up. And so numerous things going on. IT initiatives. So EHR is huge. Obviously, having one data record for patients to access within everywhere is amazing. Well, historically, we were on one system. Legacy Mountain States was on one system. Legacy Wellmont was on another. And so if you're a physician in the community, if I'm Bo Wilkes and going to a Legacy Wellmont hospital and then 6 months later going to a Legacy Mountain States hospital, trying to pull those medical records is challenging. So trying to do something like this is a major underhaul. And so we had to start developing a plan. All the while, the FTC was saying, well, you can't share important things like strategy, how much it cost, how you would do it. So we were developing a plan for the plan. And so as you sit here, and those that have kind of watched the merger, we're 60 days into the merger, maybe not even. It seems like, and I've had a lot of people ask what's going on. Well, at this point, we're still in the data collection phase and trying to get our arms wrapped around a lot of this stuff. I'm now at Johnson City Medical Center, and prior to like 2 weeks ago, we typically, JCMC typically did not communicate with Legacy Wellmont hospitals as far as what your capacity is, what your staffing looks like, what potential issues are going to be. Now we're beginning to have those conversations. This morning I can tell you what Bristol Regional Medical Center looks like. 6 months ago, would have never thought that existed. So we're beginning to work together. And so as we begin to look at what we're trying to create and we get to close, it's the end. Ballad Health exists, right? Well, as hard as the last 3.5 years was, it's actually just the beginning on what we're trying to create. So we were having a conversation out in the hallway earlier, and there's going to be some trials and tribulations along the way. Some of the things that we've proposed are going to be very challenging and very difficult. There's probably going to be some failure, and we're probably going to have to tweak it a little bit. But as long as we can learn from that, share that, and grow from that, I think it's important. Because we're beginning to look at things differently. So what do we want to do? What does Ballad Health now exist, and what are the commitments that we've made? We want to expand access, we want to improve healthcare value, and we want to attract and retain the strongest workforce. Simple, no-brainers, right? How do we do that? We've got to get creative. We've got to start thinking of things the same way. We've got to start looking at our resources, ensuring that we have the appropriate resources within the appropriate setting. And if not, we need to shift those resources. So, the document that exists that kind of outlines it is a nice little short read of 116 pages. It was approved by Ballad Health in September of 2017. And we'll kind of walk through, but the first few pages are kind of what I call legalese. So it defines kind of key terms. There's the statutory piece. But then you kind of get into, we've made some monetary commitments, we've made some obligations, non-monetary obligations, commitments, we have the managed care aspect of things, and then ultimately, how is the state of Tennessee and the Commonwealth of Virginia going to ensure that we're being successful and that we're doing the right thing? And these conversations became very interesting as we started looking for that. Now, if the document that exists in the state of Tennessee were not enough, we also have another state and another player within the aspect of things, and that's the Commonwealth of Virginia. So luckily, Virginia and Tennessee over time became closer and established a dialogue so that where Virginia terms of certification or cooperative agreement in this case look very similar to what Tennessee had. The only difference is Tennessee has a lot of measures, I'll say that, and Virginia has only 41. Now, some of those commitments are kind of check boxes to make sure that we can do them, and we will, but a little bit different thinking there, but I won't get into that commentary. So what are the monetary commitments that exist? So we're going to improve community health. So 75 million, so 7.5 million over 10 years, which it's actually kind of, it ramps up into the latter years, so it's not actually evenly divided. But we want to invest it into community health. Well, that's radically different from what our legacy systems did. And so as I mentioned, Paula Masters coming over, she is going to kind of head up a lot of what's going on there. And so we're talking about community health programs. We're talking about access to dental care. We're talking about a lot of different things that historically hospitals have not done. Dental sealants is one of the commitments one of the metrics that we're going to be scored on. To my knowledge, I'm not sure of any hospital within the country that's really focused in on dental sealants. That's always been separate. Now, the interesting thing is if you have tooth decay, you can't go under anesthesia. So it's kind of important. And so as you think to things like the RAM clinic that are going on locally, and if you haven't participated in a RAM clinic, I would encourage you to do so because it is truly eye-opening. A lot of those folks want to come and just get their teeth pulled that are falling out just so that they're out of pain, one, but also they can go have a medical procedure. The second thing, invest in services. And so very near and dear to my heart, very near and dear to a lot of people's hearts, especially Mr. Levine's part, is mental health and addiction. And I'll come back to that actually, because there's a few stories I want to tell, but obviously within that we want to expand what we can provide at not only Niswonger Children's Hospital, but then also look at expanding out into the surrounding communities. We want to focus in on rural health. I talked a lot about it, but mental health and addiction is an important one. I'll do a time check, okay. Mental health and addiction is an important one because as you begin to look around the region, medical holds within our emergency departments are a serious, serious problem. On any given day, we have at Johnson City Medical Center 10 mental evaluation holds in our emergency department trying to get into Woodridge Psychiatric Hospital. That's every day. If we pull 8 out today, I promise you we'll have 10 tomorrow. And then on the flip side, children, which we have limited capacity at Woodridge, it's even worse. And so as we look around at some of the events that are going on, is this a potential solution? We don't know. We want to look at it. Obviously, opioids is another big one. I'll speed up because I'm running out of time. I'm sorry. GME, obviously, we want to take and invest back into our programs. We want to grow Quillen College of Medicine. We want to partner with the research that's going on in the College of Public Health. We want to continue to improve those. And then, as I mentioned, kind of the EHR, we're going to invest $150 million and create a unified electronic medical record across the system. So what are our non-monetary commitments? And I can kind of fly through these. So obviously, capital plan, we already do it. We're just going to submit it to the state. A clinical council, I kind of mentioned that a little bit, but we want to engage our physicians. We want our physicians to lead based on evidence-based care. So it's not, well, I was taught this way and I know how to do it. It might not be the best quality outcomes. How can we come together and let's use what the evidence suggests to truly provide the exceptional care, which is a different way to look at healthcare. Data collection. We've historically been data rich, but we haven't been able to analyze it. So this is going to be something that's going to really force us. And then keeping all hospitals for at least 5 years to essential services. And what are those? They're basic things: emergent care, emergent OB, mobile health, telemedicine. Again, looking at radical ways and what are we successful and how can we shift to provide care to the mountain cities, to southeastern Kentucky, to provide access everywhere. Beginning to look at things. So you can kind of see the list. I won't read it, but and then ensuring that we can ultimately have helicopter access to a lot of these regions so that if there truly is a trauma, we can fly in, get them, and bring them out. I once heard a story about a helicopter that, Beach Mountain. I was a big skier growing up. It took about an hour to get there. It takes wings about 12 minutes. So, as the crow flies and at 150 miles an hour, I guess it's pretty easy to get there. So then one thing that we talked about recruiting, we want to create an equalization plan that ultimately begins to attract and retain, easy for me to say, the best people that we can. So we want to begin to look at that and shift that. So how are we going to do that? Well, and this is my last slide, so I'll open up for questions next. We feel like that there's a lot of synergies. As I mentioned, level 1 trauma, if we combine those into one, it improves quality, it lowers our cost structure. Duplication of hospitals, there's 2 in Greenville, Tennessee, there's 3 in Wise County, Virginia. Again, the arms race is not always productive. It's not always money well spent. Urgent care centers, there's a lot of duplication across the street. You look in Johnson City, downstate of Franklin, they're both right next to each other. Surgical services, again, and then kind of looking at those support services, our contracts. And we feel like by doing a lot of those things, we can begin to make those synergies so that we can ultimately get back to reinvesting this money. So with that, thank you all very much. Sorry about my time. Question?
Thank you, Bo. Yeah, we do have time for a few questions, so I'll open it up.
So I'm from Hancock County, but I have worked in Greene County for the past 20 years, and I have heard that Tacoma may be closed or maybe become a specialty center and keep one open. So that, would you say there was 2 in Greene County? That seems like that's the plan. But also, I worked at Green Valley Developmental Center for the 20 years, and we have heard that that might be part of your all's plan and looking at mental health and using that facility.
I can tell you, back to Greene County, and I know for a fact, there's a lot of rumors, obviously, as there's a lot of data collection. Typically, if there's a void, people will fill that void. So I know that they're looking at a lot of different things. What actually comes of Laughlin and Tacoma has still not been determined. Same thing with trauma. But Green Valley has been mentioned. I think even Mr. Levine has mentioned it publicly that he would like to potentially utilize that asset and leverage it and expand and grow it. However, we're just now trying to finalize our mental health plan. So there's been I think there's been a public desire and a strong desire, especially even from our end, from the Ballad Health end, but there's no necessarily plans. I mean, that really and truly is the same for everything. So as I mentioned, we had very strict requirements, and we had to document routinely that we could not have strategy conversations. And so when we sit and say that no plans have been made and no plans have been finalized, I promise that that's very much the case. So we're looking at it, and we know that we have to go in that direction, and I don't think anybody would think it would be unrealistic to combine those services, but yes, Green Valley potentially could be an opportunity, but to my knowledge, which is probably the public knowledge, there's been nothing said or done. Yes.
I know at the beginning of your speech, you mentioned that we were using a fee-for-service system. Have we not changed to a prospective payment system?
Yes and no.
Okay.
And what I mean by that is in some aspects, some of our managed care contracts are still in a fee-for-service aspect, and so if you change too quickly, you're hurting your revenue stream. And so again, managed care, the insurance companies are kind of dictating in how much do you want to go at risk and what is the incentive for healthcare systems to change. In some aspects, absolutely, 100%. In other aspects, not as much. We have shifted. We are not a true fee-for-service. We are no longer that. We are never going to be that again. So we have shifted some, but we still have to be mindful of a lot of different dynamics that go into it. So, in fact, I was at a conference 2 or 3 years ago, and a speaker actually said, hey, readmissions, when I look at what the readmission from a revenue perspective potentially looks like as opposed to the penalty, which now all that's changed, I'm probably going to take the readmission and not worry about it.
And speaking of managed care, what kind of managed care company does Ballad have?
We do not.
Okay, you don't have.
We closed, and actually a lot of healthcare systems are closing their insurance companies because it's too difficult to maintain. Again, back to the Walmart model, you have to have such a large population, and then furthermore, obviously you're not looked at as partners to insurance companies, and so you're still getting Blue Cross, you're still getting others, and so it becomes a challenging dynamic. And so as you look across, Mercy and Cincinnati just closed theirs, Legacy Mountain States closed theirs a couple years ago. So insurance companies, and as part of our commitments, we committed that we would not own or operate an insurance company.
Other thoughts, questions, comments?
Yeah, I have a question. As a community member, I know I've been hearing people, one of the things that they're most worried about is monopolize care. And I was wondering what sort of stopgaps or what kind of entities over that could rest the minds of the people.
So one of the things I think that people are fearful of from a monopoly standpoint is cost. So we have put some provisions in as far as we'll control our cost, and we have to provide documentation to the state as far as what our cost structure looks like. And so I think it's a very complex aspect of how things are, and so but we have to meet those. We have the quality aspect of things, so actually we have to sustain or grow our quality metrics. So there's that aspect of things. So there's a lot within these commitments that forces us to ensure that a monopoly doesn't exist. But again, as we look, some of the disadvantages of potentially creating a monopoly, or the advantages, whatever, however you want to look at it, we don't have to compete on certain aspects, and we can take that competition money and put it into academics and research and stuff and grow those aspects of it. So there's a lot of great things going on, but I mean, it still is the predominant healthcare system. But as you look across the country, systems are growing rapidly and their footprint is expanding. And so I often ask the question of, as large as we are now and potentially what footprint we cover now, in 10 years, is that going to be really that different? Personally, editorial comment, I don't think it is. I think healthcare systems are going to regionalize and grow as much as they can because they need that leverage, they need that scale to produce results.
I think that's the biggest concern with people in the community is that, they're gonna get to the point where they're gonna have to pay just whatever is told to them.
Right, and so as you look at one of the slides that I took out, as you look across the country, some of the folks I even interact with would say, I just wish we'd go back to Johnson City Medical Center, let's forget all the other 20 hospitals, let's do it. And since 2010, there's been 83 hospitals, independent hospitals that have closed. Independent hospitals are a thing of the past. They're combining systems because they can't, just the cost structure and the overhead, the reporting requirements, even outside of the COPA, are so immense that you need that scale to be able to do a lot of that stuff. And then as you look to like Johnson City Medical Center, as we begin to build our stroke program, now all of a sudden the stroke care that we provide across a 21 hospital system, that's all referred back into one single hospital where we have neuroendovascular and everything that's being able to provide services that otherwise would not have been able to do. We really began to create those models that are unique. And so whether you're in Marion or across the town in Johnson City, typically within 45 minutes to an hour of stroke onset hitting, we can get you somewhere where we can start care immediately.
Speaking of her question, I know when Greg Neal gave his Breakfast with the Expert speech here in 2015, this was long before the merger actually happened, and he said that the two legacies had come up with 6 commitments that had specific numerical goals that they were going to meet as Ballad Health, and if they didn't meet those goals, then the states of Tennessee and Virginia had the ability to disband the company because they had made contracts with those states that gave them that power.
Correct.
Is that the way that it actually went down?
The latter part is, the first part, there's a lot more than 6 commitments.
Okay.
And so, but yes, the state of Tennessee can at any point revoke our certificate of public advantage, and the Commonwealth of Virginia can revoke our cooperative agreement and force us to disband.
So if Ballad does become a monopoly in the way that it starts doing more outlandish things with prices and things like that, in that case, the states would have the ability and would be likely to disband.
Mhm.
And
actually,
that threat is something that Ballad is going to have in mind as an incentive not to jack up prices like that.
right, and there's also fines that are associated with that, and there's different levels of fines. I think pricing is one. If we don't meet it, it's like $1 million fine.
That's pretty bad.
Yeah, so there's financial incentive for us even before we get to disbanding. So we can be hit with financial aspects of things.
Thank you, Bo, very much. This
Absolutely.
was very informative.